Thank you, Chairperson, for your kind introduction. Today, I'd like to talk about RF ablation of thyroid from benign to malignancy. This is my conflict of interest. Korean Society published our guideline 3 times, 2009, 2012, and 2018. Here is our 2017 thyroid RFA guideline. The guideline suggests 3 indications for benign thyroid nodules: patient with symptomatic cosmetic problems and patient with toxic thyroid nodules. The guideline suggests 3 standard techniques: perithyroidal lidocaine injection to control pain, transseismic approach method, and moving shot technique. This image shows perithyroidal lidocaine injection during RF ablation. Lidocaine injection at perithyroidal soft tissue, we mean the thyroid capsule. There is abundant sensory fibers. Injection of this area is very effective to control pain during RF ablation. This movie file shows a transseismic approach method and moving shot technique. The electrode approach is made from medial from isthmic area to thyroid nodules. Like this, transseismic approach. And the needle tip locate the posterior part of a thyroid nodule and then move anteriorly like this. The electrode move continuously. This is called moving shot technique. On the next day of RF ablation, the ablated nodule increased its size because of swelling of nodule by heat. And around 1 week, the treated nodule started to decrease its size, and the rapid volume reduction is achieved during first month after RF ablation. After 1 month, nodule volume reduction is usually slow. This image shows before and after RF ablation. Well-treated nodule shows decreased echogenicity from isoechoic to markedly hypoechoic, and disappearance internal vascularity after radiofrequency ablation, and you can see the decreased its size. This image shows thyroid dedicated internally cooled electrode compared with 17 gauge long electrode commonly using in the liver. This thyroid dedicated electrode is short for easy control and thin to minimize normal thyroid injury, and there are various sized active tips, so we can use these very variable tips according to the size of thyroid nodules. This table shows active tip size from 4 mm to 1.5 cm and proposed RF power from 10 to 18. I personally prefer the 7 mm active tip for less than 3 cm thyroid nodules. Here is the short-term clinical outcomes less than 2 years. Our team, the yellow colors, used initially internally cooled electrode, but now we use thyroid dedicated internally cooled electrode. The European doctors used umbrella type electrode, but recently they also use the same electrode. Volume reduction is very excellent, around 8% of volume reduction at 1 year. The volume reduction is excellent, like this, around 70 to 90% at 4 to 5 year follow-up. However, the thing is regrowth. That means recurrence of the tumor from up to 28% was reported, and the regrowth followed delayed surgery during follow-up. Is the main problem at long-term follow-up. Sometimes a delayed surgery shows malignancy of treated nodules. This image shows a huge thyroid nodule. The trachea is deviated to left side. After radiofrequency ablation, very large nodule initially, the treated nodule decrease markedly like this. Before and 3 years after RF ablation. Another case shows 7 cm predominantly solid thyroid nodule was managed by 3 times of RF ablation. You can see the markedly decreased at 1 year follow-up. 42 months, 55, 72, 80 months follow-up shows markedly decreased thyroid nodules like this. Nearly disappeared at 10-year follow-up. The neck bulging is usually well controlled by radiofrequency ablation. 6 months, 1 year, and 1.5. The markedly bulging neck was nearly normalized. What about the safety of thyroid RF ablation? This multi-center study enrolled more than 1,000 patients from 13 Korean institutions, and the major complication rate was 1.4%, and the CKLA was 0.14% in this study. Let's move on to the recurrent thyroid cancer. And Korean guidelines suggest 2 indications for recurrent thyroid cancers. One is cure, the other is palliative. Cure suggests we treat any visible cancers on ultrasound, and the guideline recommend a combination of RF ablation and radioactive iodine therapy to increase the complete treatment. Palliative ablation suggests we treat tumors causing cosmetic or symptomatic problems, or tumors near critical structures such as airway, skin, nerve, and vessels. The guidelines recommend a combination of RF ablation and radiation, TKI such as sorafenib or lenvatinib, and radioactive iodine therapy. This case shows a single metastasis on left OP bed before radiofrequency ablation. This is the ultrasound image 1.5 after radiofrequency ablation. At 9 years, the treated tumor was completely disappeared and there was no recurrence on ultrasound. Serum thyroglobulin level was undetectable at 9-year follow-up after RF ablation. CT scan shows intense enhancement of the tumor. After radiofrequency ablation, enhancement was disappeared and decreased, more decreased and completely disappeared. There was no recurrence at a 9-year follow-up. This case shows palliative treatment. Recurrent follicular carcinoma involving trachea and the esophagus and the right side recurrent laryngeal nerve. As time goes, the tumor grows inside the trachea like this. Tracheal lumen is markedly narrowed at that time. So the patient complained of dyspnea and visited our emergency room. We immediately applied the tracheal stent to widen the tracheal lumen and then ablate the tumor by radiofrequency ablation followed by external beam radiation therapy. At 49 months follow-up, the tumor around the esophagus is slightly enhanced at that time. However, symptom was stable at 49 months follow-up. Another case of metastatic thyroid cancer at left flank, left axilla, and the right flank, like this. Both tumors were managed by radiofrequency ablation. This is the picture after radiofrequency ablation. The treated tumor was well controlled by radiofrequency ablation. I would like to stress thyroid protocol CT is somewhat different from ordinary neck CT. Our 2021 guideline proposed the thyroid protocol CT. Here is the protocol of the CT. And when you compare the conventional CT and thyroid protocol CT, can you see the metastatic tumor in this conventional CT? Thyroid protocol CT definitely shows focal enhancement here inside the lymph node. Here is a metastatic tumor. It's definite on thyroid protocol CT as a well-enhancing nodule, but it is uncertain at conventional CTs. Therefore, thyroid protocol CT is useful to detect metastatic tumor and post-RFA follow-up. Let's move on to the primary cancer. This table compares the active surveillance and the radiofrequency ablation data. This is a meta-analysis of more than 2,000 patients of active surveillance. How about the tumor progression rate? Was 6.9% in this meta-analysis, and the surgery due to anxiety was reported up to 32%. This is another metastasis after summer ablation. Number of patients were 470, and the tumor progression was 0% in this meta-analysis, and the surgery due to anxiety was also 0%. After this meta-analysis of summer ablation, there was 4 studies were reported more than 5 years, 5, 10, 5, 5 follow-up studies. These studies shows tumor progression rate was from 1.1 to 2.6%. Surgery due to anxiety was reported from 0.5 to 1.1. So this table shows 5 to 10 year follow-up result of active surveillance and radiofrequency ablation. Radiofrequency ablation shows better tumor progression rate and lower surgery due to anxiety rate. Let me introduce RFA for PTMC Korean court. Here is a 10-year clinical experience of Korean court. This study enrolled 71 low-risk PTMC from 65 patients. This is unpublished data. The mean follow-up period was more than 12 years, 145 months. And the mean RF ablation session was 1.2. And we used the active tip size of 5 mm. Mean RF watt was around 20 watt of RF power. The clinical outcomes shows a complete disappearance of tumor was achieved in 2 years in all patients, and there was no local tumor recurrence at 10-year follow. What about the cumulative disease progression rate? In this study was 7.7%. However, there was no local tumor recurrence, no cervical lymph node metastasis, no distant metastasis or procedure-related death. However, new PTMC at remnant thyroid was detected in 5 patients, and 4 patients were managed by radiofrequency ablation, and 4 patients were managed by lobectomy. Therefore, conversion surgery during follow-up period was 1.5%, but no conversion surgery was observed due to anxiety of the patient. There was only one major complications. Patient with subclinical hypothyroidism was managed by thyroid hormone replacement, and there was no unpredictable complication during the follow-up period was more than 20 years of this study. Here is a small thyroid cancer. Here was managed by radiofrequency ablation. Immediately after radiofrequency, you can see the ablation of thyroid tumor and normal thyroid gland, and it was completely disappeared at 1 year follow-up. Here is a well-differentiated macrocarcinoma. This patient was inoperable status, so we performed the radiofrequency ablation for these tumors. 1 month after RF ablation, 5 months, 1.5 years, and 31 months. the tumor was markedly decreased and there was no lymph node metastasis. How about the anaplastic carcinoma? Here is a huge anaplastic carcinoma involving internal carotid artery, common carotid artery. It was managed by 2 times of RF ablation, and this is 40 days after RF ablation. You can see the ablated tumor was increased compared with the initial tumor size. That means the doubling time of anaplastic carcinoma is very fast, so radiofrequency ablation is less effective in anaplastic carcinoma. I would say RF ablation for benign, recurrent, and primary thyroid cancer is an effective and safe procedure. However, we should understand the technique, devices, and complications for safe and effective radiofrequency ablation. Thank you very much for your for your attention.